Yeah, you're good to go.
So folks, my pronouns are he and him. I'm using my company template. I typically use a Western one, but this is sort of a preset presentation I give. So again, my name is Dr. Nitin Mohan. Please feel free to call me Nitin. Raise your hand at any point in the presentation or just interrupt me if you have any questions. So I open up my global health course every year, and I teach students who are enrolled in the Masters of Management and Applied Sciences program at Western University under the Schulich School of Medicine and Dentistry. And I also teach students enrolled in the Master of Public Health program, again at Schulich at Western. So I always open my slide with this to sort of frame the discussion. We have lived our lives by the assumption that what was good for us would be good for the world. We have been wrong. We must change our lives so that it will be possible to live by the contrary assumption. What is good for the world will be good for us. And that requires that we make the effort to know the world and learn what is good for it. So I typically like to cold call in my classes, but I won't do that here. I'll ask the audience if anyone has any sort of quick reflections on this quote.
You guys can also feel free to type in the chat, or if anyone raises their hand, we have our team on the lookout. So anyone have any input?
So what we're trying to establish here is the focus on planetary health as a key informant of the health indices of our societies. So typically, at least my perspective when I entered medical school is I looked at sort of cause and effect. I have a patient in front of me. What is the issue? What am I treating? How am I going to go about it? I was not a medical student who really paid attention to the social determinants of health. Typically, by virtue of living in a certain country, having better health outcomes, being able to access certain healthcare treatments, having a family doctor, having adequate food and nutrition, all these factors that are sort of planetary health driven, they weren't necessarily on my radar. And I think it's important when we talk about global health is we have to understand planetary health and population dynamics. So we know that our resources are finite. We know that the world isn't necessarily distributing these resources equally. And we know that due to this unequal distribution of resources, we have downstream health outcomes that we're seeing in many parts of the world right now. So quick question to folks on the line right now. Does anyone want to take a gander at what is global health?
Yeah, I think global health is like you mentioned, like we tend to look more downstream, but learning to look more upstream and focusing on health promotion and equity versus like equality.
Yeah, absolutely. I like that. Does anyone want to add to that?
I can pipe in here. I also think that there's this concept of global health being the global nature of things, that you have to get out of your house, you have to go to a foreign country to do work, but you can do a lot of global health work within the comfort of your home, and that's something that resonated with me in the present moment at least.
Great, I like that. So we can advocate, we can be part of global health regardless of our geographical location. Keshi, I might pick on you later and come back to that comment and be forewarned. So according to the WHO, health is a complete state of physical, mental, and social well-being, not merely the absence of disease or infirmity. The Alma Ata Declaration adds to that, and it says health as a socioeconomic issue and as a human right. So we understand the socioeconomic factors that impact health, but we also view health as a basic human right. So it can be defined in various and contrasting ways, depending on one's standpoint, perspective, or values. and we factor in differing worldviews and disciplines, the process of negotiating health is complex. So an exercise I have my students do is I have the cohort every year come up with their own definition of what is health. Because if we can't define health, I'm not sure how we can understand what global health is. So what might be a definition of health here in Ontario may not be the same case in Bangladesh or Lagos, right? So one aspect that's often added to this definition is planetary health. Another is spiritual health. Is there anything else that you folks think is important to add from your perspective? My understanding is many of your students who are enrolled in universities during a once-in-a-generation pandemic, and you're starting to see life unfold in front of your eyes. We're testing systems, testing beliefs in real time. And to me, it's quite fascinating because we're able to get a direct reflection on our processes, right? We have things in place in hopes of preparing our societies for an event like this. And we're essentially seeing the bottlenecks. Would anybody want to add in? So we talked about socioeconomic. To me, that encompasses political will. And when we talk about global health, amongst many other things, we have to talk about the political will to support global health and or hinder it. So we're at this sort of, I won't say tipping point, but we've been at this point for quite some time where we take a look at the healthcare field as a whole and specifically global health. And we start to realize that we're playing different games depending on what part of the world you're in. So if you're in the West, oftentimes you have the luxury to pick from various downstream modalities. We spend a lot of money in North America on cancer treatments. But maybe not as much money on upstream nutritional programs that can be viewed as preventive in terms of our disease onsets. So we understand that the demographics of populations in Canada is skewed towards baby boomers. So I think by next year, 40% of Ontario residents will be at the age of 65 and over. Right, that's a large chunk of our population. Right, so if we're playing two different games, it becomes difficult to make progress. So it's a fun slide that I like to show my students. Again, I'm not going to spend much time on this. We'll get back to this later on. But I'm going to sort of talk about some of the reasons that got me thinking about global health in more detail. So in 2015, I was training at the Lyndhurst Rehab Center in Toronto through UHN. And I think in the medical profession, and especially medical school and residency, you start taking account of which patients are doing better than others and why. So you're following whatever decision trees you've memorized, and you're going back to lectures and your notes, and you're thinking you're doing everything right, but your patients aren't improving. And then you start to pick up on certain trends. So things like social community contexts, economic factors, access to healthcare and education. And I think this was sort of an eye-opening aspect to me. I had the ability to train in various health systems across the world. And I think, over time, I've sort of been made aware of these issues, but not to the extent as my experience here at Lyndhurst. So in global health and in healthcare specifically, in my opinion, it matters if you know what you're thinking about and how to think. And the quality of your life is determined by the quality of your questions. And I think this is very important when we talk about the patient-centered approach. So again, if we take the global health lens, we sort of have the 50,000-foot view of what is affecting our societies. But we have to have this sort of swing where the pendulum goes from 50,000 to directly in front of a patient. And what's important in global health is understanding the factors that push and pull the success and improved health outcomes of our patients. So from my worldview, when I was a first-year medical student, I had a few options. So either family medicine, merge, maternal, surgery, psychiatry, OBGYN. And A life of global health or public health really wasn't on my radar. If I'm being honest, I'm not sure I even knew that these fields existed. Right? To me, the only outcome of medicine was one of these specialties. And I imagine for some of you, that may have been the case. What I appreciate about global health specifically, and public health, is that we work in systems entirely. And systems don't have to just be the systems in public health in terms of economic or education or healthcare, but essentially systems can be viewed in all aspects of healthcare. This is a nice little slide that just shows, you know, the ability to sort of take a step back and look at something as a whole. And when I was in medical school, the thing that we were taught is that as physicians or as med students, you will either teach, treat, or research. We were often told about advocacy, that our roles as physicians or global health professionals sort of, you know, center around this space. And I'll ask this question to the folks online who are either in medical school or hoping to get into medical school. What are your views on being an advocate in healthcare today? I tell my students at the beginning of every lecture that I'm extremely comfortable with awkward silences to my own detriment. So I'll give you folks a second to think about it. Maybe I can paraphrase the question. How comfortable are folks advocating nowadays? Do you feel like...
Start off?
Go for it. No, please go for it.
I think I can start off by sharing, and then hopefully someone can add in. But just from my perspective, I feel like there are two things involved in terms of advocacy. One is we understand more than ever, and as you've highlighted so far in your talk, that health is very contextual, and there's so many other factors contributing to it, such as the social determinants of health and many other aspects of our lives. So when advocating for health, it may not always look like, a stereotypical, health topic like mental health or something along those lines. It might just look like, advocating for the homeless or advocating for marginalized populations such as refugees who fall through the cracks of healthcare. So it kind of, advocacy in healthcare kind of starts to look a little bit more broader nowadays. And I also think that social media and advocating online can sometimes be a little dangerous, especially given that everybody has that voice and everybody kind of is highlighted nowadays. And things can seem very polarized at times. So I'm not even going to say at times, I feel like all the time things seem so polarized. So it can feel kind of frightening to advocate online or voice your opinion. But at the same time, I feel like it's a double-ended sword, because we have the opportunity and the privilege to voice our opinions online. So that's also a privilege. But yeah, there's good and bad to it.
It's a great comment. Thanks for sharing that. Does anyone else want to add to that or possibly push back?
Yeah, I wanted to add to that as well. I was thinking another way, I think with advocacy, I've always seen it as spreading the word and making sure to talk about it, which is definitely important. But now I feel like another way to advocate sometimes is just by starting to do it, because we learn so much about what people are already doing, and sometimes you just have to get started, and then from there that's a great way to send the message as well.
I appreciate that that comment. I think action is quite important. Do you folks feel comfortable advocating in your roles? So I say this to my students, and I think it applies to everyone in this room. You folks, by virtue of where you're located geographically, in the educational programs that you're in and the knowledge you have, are within the top 1% of health literacy in the world. All right, so just let that sit in. Whether you're in med school, whether you're an undergrad, whatever role you're in, you're within the top 1% of health literacy globally. But do you feel like you have the ability to advocate, and do you feel comfortable advocating?
I think for me, especially if it's kind of like the bystander effect, if someone else does it, then it's easy for us to post the same thing. For example, if someone's posting about this global health issue, then like I would be, and a lot of people are doing it, then it's like easier for me to like also advocate and like publicize it, which is, I feel like it's not also, um, it's not like the best way to do it. And it's kind of hard to put yourself out there or put whatever you're passionate about out there without someone else backing you up. So I think that kind of also pushes people back from actually advocating, but I don't know. I think that's just kind of how I see it. Most people will do it if someone else is doing it.
Yeah, and it makes it a bit more comfortable and easier to do that, right? Putting yourself out there is not necessarily fun. It's not easy, and I can tell you regardless of what stage you're at in your career, the Twitter sort of backlash and the hate that you get for saying certain things is not fun to read. So Abhishek, I appreciate that comment. We have another comment in the chat from Angelique. She says, or he says, I apologize if I'm incorrect here, but I do feel comfortable advocating, especially when it is something I'm passionate about. I have the ability to, however, I may not at all times. Another great comment here. I raise this issue because in the global health fields, especially in global health and public health, largely our role centers around advocacy, but not advocacy for the sake of promotion. I think true advocacy in terms of highlighting the issues. Anissa mentioned action, right? Pushing action forward and finding solutions to problems or being a champion in that regard. And so part of advocacy looks at equity, right? And I'll center it around the response to COVID here in Canada. And one of the issues that we're dealing with in Ontario is something around paid sick leave. So we're asking certain folks to open up our economies or keep them going. And these same folks don't have the luxury of taking time off of work if they're feeling sick. And this is regardless if they have COVID or not, just if they're symptomatic. Additionally, you know, in the areas that are hardest hit in Ontario, so if you look at Toronto and Peel, parts of Ottawa, isolation facilities aren't necessarily in abundance. So we're creating an inequitable system, and then we scapegoat folks living in these areas, saying that they're driving COVID case counts up. And if you look at the world from a global health standpoint, we do the same thing. So global power was typically in the West, right? You can make that argument for about 10 or 15 years ago. And then we saw LMICs, so India and China, make a rapid rise in terms of global dominance and wealth. So typically folks went from a world where they were trying to afford shoes and a bike to where they can afford a car. The middle class increased. Now the population in these countries is relatively larger than what we see in North America, so there are many more cars. And we have an issue with climate change. So now we're asking folks in that part of the world to curb their behavior when they've been watching the West do this for all this time. I'll put something on your folks' radar. I'll put it in the chat later, but if you want to see a fascinating lecture or a TED Talk, Hans Rosling, so H-A-N-S, last name R-O-S-L-I-N-G, has a fascinating talk about population dynamics. It's absolutely incredible, and I urge you folks to watch the lecture he did in 2010 before you watch any of his new ones. It really sort of puts into perspective what our role is in healthcare. So as physicians, we have a duty to advocate for those who are disproportionately made vulnerable to systemic and structural factors. So this is something that I've learned recently, but I think it's quite important. We often use the term vulnerable societies in global health, vulnerable populations. The reality is that folks are made vulnerable through the systems and structural factors that already exist, right? To say that someone is vulnerable, they are vulnerable, really it's the societal and structural issues that put them in this position. We talk about representation in global health. Our governance should reflect our societies, our health systems also, right? So if you have folks in government that may not understand the need for paid sick leave because they have paid sick leave, or they don't understand these. In the global health, the majority of global health leaders in the East are often from the West. So folks born and raised in Canada and the US, who've been educated in Canada and the US, but then head out east to lead global health initiatives, right? And I think, you know, there's some discussion here that can be had in terms of the effectiveness of that, and perhaps revisiting that system, right? So again, a seat at the table in terms of global health specifically, physicians who are on the front lines being asked to execute policy, it's important that we're part of the policy decisions, right? So the disconnect between policy and actually implementing that policy on the ground seems to be growing, and we have to narrow that gap in global health, right? So we're big on data, and I work in the world of data. All I do is create surveillance systems, more recently, specifically for low to middle income countries. And it's always an ethical issue I have is, am I sourcing the correct information? Who's using that information? Who will be affected by it, right? Are we actually encompassing the true demographic scale of society, right? And I think it's tough to do that, but it's something that we as physicians or folks in healthcare and global health have to have an acute eye on, okay? And one of the reasons is that as physicians, you're often directly involved in your community. You understand what drives your patients. As global health professionals, whether you're in epi, if you're in health promotion or in policy, having that lens on the community level is quite important. And so Keshi, I'm gonna loop back in with you and pick on you for a second. So you're absolutely right. We can be part of global health regardless of our societies, but we have to be mindful that we may not have lived experiences with the same way folks do on other parts of the world. And in the West, what we've done for many years is we've done something called helicopter research. So we leave our nice, you know, situations here in the West, we go out east, we set up these research initiatives, we get the research and we leave, right? So we call this community-based research in global health, where the community has to be involved with the research, right? Is there any benefit for the community in us doing the research? Do we understand how the community perceives whatever issue or perceived health outcome that we're trying to accomplish, right? Are the cultural factors understood by the researchers who are implementing the research, right? So when we talk about global health initiatives, if we don't take that community and cultural lens, we're doing a great disservice. And I think we're seeing that now even in the diaspora of Canada, where Canadiana, what was traditionally thought to be Canadiana, may not be the case in 2021. The need to have community-based approaches to our health systems is quite important here, right? Language-specific healthcare, culturally specific healthcare, governance of healthcare structures, right, from a cultural standpoint is quite important. And so we have a sort of microcosm here in Canada, and we can sort of take a wider lens and see how that's done on a global scale. Some of you folks know this lady right here. This is Dr. Philpott, and then the lady to her left is Dr. Theresa Tam. I got a chance to work directly under Theresa Tam, and Dr. Philpott's been a great mentor to me throughout my career. And for me, this has really sort of heightened my interest in global and public health, is having that lens on health equity. And specifically in Canada, when we take a look at the Indigenous populations and the lack of healthcare and health service provisions that these folks have, it's something that's eye-opening. You know, if you ever want to go down, I won't even say rabbit hole, it's something that I think every Canadian should understand, is the challenges that Indigenous populations face, historically have faced, continue to face. And I think, you know, it's sort of an onus of us in the healthcare field to continue to do everything we can to address these issues. On the right, you'll see these words that have multidisciplinary, interdisciplinary, evidence-informed, data-driven, equitable, inclusive. I'm sure all of you folks have read these a million times. Some of you understand it, some of you don't. Some of you don't know how it applies to you. Some of you don't know where you fit in, if you fit in on the data-driven side or interdisciplinary or multidisciplinary. This is the world that we live in constantly in healthcare and global health. You jump from multidisciplinary to interdisciplinary to data-driven to equitable. You're just basically on this spectrum. Right, and this is another little picture that helps depict it. Ideally, where we want to be is in this world right here, transdisciplinary. Okay, especially in the global health field, right? Typically what happens is we sort of live in the disciplinary and multidisciplinary field. We occasionally get to interdisciplinary, and when we're really lucky, we get to transdisciplinary. Okay, it takes a lot of effort for us to get here in the global in the global south. Okay, it's a bit easier in the global north due to the systems we have in place and possible funding models, but really difficult in the global south. And the reality is when you're in a transdisciplinary world, you're much more efficient and cost effective. Right, and you can see why that's quite important in global health. So we mentioned that we are in a once-in-a-generation pandemic right now. And for folks who don't know this, we in the epi and infectious disease world are calling this pandemic 1, which would mean that pandemic 2 is coming. And we feel that that's quite realistic, whether it's 10 years or 50 years or 100 years from now. We think it's an inevitability. There have been virologists and geneticists who mapped out, and actually infectious disease specialists who mapped out our current pandemic in 2013, which is why we had certain resources in that part of the world, because the gene sequence from SARS-CoV-2 virus was sort of understood to take one more mutation. So when we talk about global health security, this is where we can start really nerding out into the infectious disease surveillance side. So essentially global health security is the activities required to minimize the danger and impact of public health events that endanger the collective health of populations living across geographical regions and international boundaries. So really fun technical definition, but what does it really mean? Okay. Essentially protection from infectious disease threats. I'll let folks just take a look at this slide for a second before I start to get feedback. So to provide some insight to you folks in the background is that every country should have a pandemic preparedness team, right? And usually the United States sort of leads this initiative. In 2016, a certain gentleman took over and he disbanded this team because he just didn't think it was important. And then through his trade agreements, he thought that it wasn't important to have his lead infectious disease physicians in certain parts of the world because he thought it would be a leverage ploy. Clearly those decisions weren't that great. But looking at this chart, does anything stick out to the folks who are online right now? Anything surprising?
I can pipe in here. I kind of find it very surprising that Canada is one of the most prepared countries, yet we're still struggling a lot. But if you also look at African countries that are least prepared, that the pandemic has kind of made its way to, I'm sort of wondering, what are their current efforts to offset the effects of pandemic, essentially?
That's a great question. So yeah, Keisha, you're absolutely right. I think I'll go to one more comment before I answer your question. We'll pull this up. Andrew says, I find it interesting that Australia is so well prepared compared to all the other surrounding countries. Absolutely. So I'm glad that you folks are picking up on this. It's funny seeing this slide today, right? Based on how we perceive Canada to be doing. But if you look at our neighbors to the south, up until a vaccine rollout, we were sort of the gold standard in North America, right? Folks are thinking that we're doing a great job. Our numbers are relatively controlled. Meanwhile, all of us in Ontario are waving our hands, screaming out loud, saying, hey, we can be doing more, things can be better. So there's certain factors and indicators that go into these. So certain things like pharmaceutical storage. So during the first wave, one of the discussions we had at the national level was, what are the 3 top drugs we need for cardiovascular disease? Because the supply chains are disrupted across the world. So we may not be able to source all the medication we need. What are the drugs we would be giving patients who are diabetic? Can we just use metformin across the board, for example? We may not be able to source all the possible medications we need. So part of global pandemic preparedness is your ability to have large pharmaceutical stores to protect you in the situation, the ability to deploy and access hospital beds. Canada relies heavily on the US for certain emergency responses, right? We don't have the hospital capacity in our country that folks in the US have. Our military is also not scaled up to the level of the United States. The United States has essentially massive helicopters that are planes that can land anywhere, and you have a full functioning hospital with state-of-the-art diagnostics. In Canada, what we do is we leverage our relationship with the US in these situations. In a pandemic that's affecting, our global partners equally, we didn't have the ability to source resources from the South. So we were sort of left out in the cold. And I think what it's shown is that our public health systems have been chronically underfunded in Canada. And that really sort of took precedent throughout this process. Then we look at places, and you mentioned Africa and being least prepared. And there's been some successes here in Africa, actually, with the pandemic response. Can anyone take a guess how those successes came to be? So in a continent where resources have been scarce and they've been plagued with previous outbreaks, let's say Ebola, they've been dealing with HIV, AIDS, what they were able to do in certain parts of Africa were leverage existing systems in place and essentially convert them or utilize them for COVID responses. But they had some basic infrastructure that was already there. Whereas and this is my personal opinion, and I won't put in any knowledge I have from the federal side, but I think in Canada, our understanding of a global pandemic in terms of what we're seeing right now may not have held true, right? I won't be able to dive into more detail, but I'll let you folks sort of let that sit in. So when we talk about levels of prevention in global and public health, does anyone want to take a gander at what we're looking at? Primary, secondary, tertiary. So primary, we take a look at detection and management of risk factors for future diseases and outbreaks. Secondary, we're talking about screening of asymptomatic individuals early on for disease outbreak. And last, improved management of patients with actual disease outbreak. Does this seem like a wholesome prevention strategy? Are we missing anything? Quick question. For primary, when we talk about detection and management of risk factors for future disease and outbreak, do you folks understand how deforestation sort of fits in here? So we'll get a little nerdy with the global health side. So what we have is we have a rapid increase in population across the globe. In order to house population and in order to make our societies grow, oftentimes we cut down forests and green space. Disease vectors often live in these forests and jungles. So an example is you have bat droppings, a rodent eats the bat droppings, a certain cat eats the rodent, and it gets recycled in this ecosystem. Then you sort of cut these trees down to build additional housing or societies, and the ecology and the wildlife sort of disperses from these ecosystems. And then there's a jump from a vector from a certain animal or a cat, for example, let's say civet cat, and then it jumps into a human. And then we get these global pandemics that we're seeing. And in general, when it comes to a pandemic, there's two factors that we look at from infectious disease, public health surveillance side is how contagious is the virus and how deadly is the virus. So something that's really deadly doesn't have the opportunity to be super contagious because folks tend to die before they can give it to someone, right? On mass scale. Things that are really contagious but not as deadly overwhelm our health systems, right? More than the amount of deaths. And then you have sort of the perfect storm where something is very contagious and equally deadly, right? So COVID is a little bit more on the contagious side, not as deadly, but there's going to be a pandemic due to a virus that has that perfect balance. And we're talking about catastrophic human loss, to the 100 to 300 million total level, which is what we anticipate pandemic 2 to be like. So back to levels of prevention in global public health, there's one thing that we're missing. and that's primordial. Okay. Targeting upstream forces that drive the disease outbreak. Global health is already tied for resources. In public health and global health, we have to work in an upstream model. Prevention is key. It is much cheaper to prevent a disease than to treat it, exponentially, right? Whether it's global health or local, you want to prevent as much as possible, okay? So when we talk about targeting upstream forces that drive disease and outbreak, addressing something like deforestation is quite important. Addressing something like population dynamics and the increase in global population is quite important. And I don't think we'll have time to get into this right now, but one of the factors that drives global population is infant mortality, right? Maternal and infant mortality. So if you think about a society where they have, a high infant mortality, a family may have 7 kids with the hopes of 4 surviving, right? Whereas when you have improved health literacy, you can family plan, and you know that if you have 2 to 3 kids, all of them will survive. So when we have part of the world who is, exploding from population level, we can see how that sort of translates into global health disparities, whether it's deforestation, lack of resources, food, nutrition, etc., economical issues. Okay. Again, we want to live right here. This is our goal in global public health, is to live in primordial. Okay. Where we are here right now, and I think we're basically living between primal and tertiary, depending on where you live in Canada and where your response is. So if you're in the Atlantic provinces, you guys are doing great. You can sort of address things, and attack them quite quickly. I think we heard about New Zealand sort of woke up the other day with 3 cases and they shut the entire country down, more or less, right? When your case counts are low enough, you have the luxury of being here, right? And again, you can see the level of effectiveness is proportionate to where you are in sort of the planning cycle. Lastly, just to give you folks some exposure on this, when we look at a virus like Ebola and we do a mapping process, this is sort of what an initial map looks like. When we talk about the responses, so we're looking at disease characteristics, sociocultural factors, sociopolitical, public health measures, socio-environmental, migration and population dynamics. And from each one, there's a node. Okay? From each node, we're trying to assess how do we gather the correct information to build an indicator around these nodes. Okay? This is essentially what we would do in the initial surveillance planning stage. And I should give credit, one of my former students, Rochelle Pereira, who's an epidemiologist at the Public Health Agency of Canada, the tuberculosis team, actually put together this phenomenal map. Okay, this is not to overwhelm you folks, but what I want to do is sort of shed light on some of the processes that we have. And for those of you who are going to enter the global health field, this is something that you should get very comfortable with doing. Okay, you should be able to pop in COVID-19 here, pop in MERS, pop in SARS, pop in any TB, and you should be able to go throughout the entire process. Lastly, I'll just sort of touch on certain careers in the global and public health field for folks who are interested. I know I think we're at 6:40, so I'm taking a bit longer than I thought. But really, I think you folks are very well versed with medical officers of health, whether it's a chief medical officer or local medical officer. But oftentimes what we do as physicians, so I'll take the physician angle first and then I'll go more general, is act as a medical advisor or sort of program leads, providing that actual acute care lens. If you're on the policy side or the program side, oftentimes you can hop into any one of these roles. The things I have in bold are the areas that I've worked in. So if folks have any questions about that towards the end of the lecture, I can happily address them. The specific work I've done in surveillance for folks who are interested is, I think the one that matters is this one right here, Melissa, which stands for the Multilateral Information Sharing Agreement. I think what's important for us to sort of detail is that provinces and territories work independent of the federal government. I encourage everyone to understand how the funding model of healthcare works in Canada, how the federal government allocates money to provinces, how the provinces determine how much money is needed for healthcare, how they build that in through taxes. So what happens is at the federal level, we may need information on TB rates across the country. The reason we need this information is we have a pact with the WHO and the UN where we share our TB rates with the rest of the world in order for us to have a direct monitoring system on TB. So for example, if TB starts spiking up in a part of the world, we need to know why that's happening. Information is not easily shared. So for example, if Keshi represents Ontario and I represent British Columbia, I'm just not sending Keshi information. There has to be certain things in place. What information am I sharing? How identifiable is that information? So am I protecting the patient's information? When is Keshi allowed to share that information? So embargo dates. This stuff becomes very complicated when you talk about sharing data, specifically health data. The privacy laws behind it don't necessarily make it easy to share. And I don't think that's a bad thing. I think we have a duty first and foremost to protect patients and their data. Our systems have to factor that in first before we build out anything else from a data side. The other thing I'll highlight is that creating clinical guidelines are not as easy as it looks. So oftentimes we read the end product, but when you're on the other side and sourcing information, determining what should be part of guidelines, it's extremely difficult to understand how that applies in real world. So what does it look like for a physician seeing a patient to follow these guidelines? How realistic is it? How does this change across demographics? And you know, one thing I'll throw in before I leave is that in Ontario, we just started collecting race-based data in 2021. So just factor that into how we were making our policies and our guidelines if we just started collecting that information right now. So before I close off, I think I've sort of given folks a little smorgasbord of a bunch of global public health stuff. If I can leave you folks at one thing is I would urge you all to understand how population dynamics are going to change how healthcare is delivered, not just in the global south, but locally as well as we move forward. So thank you folks for giving me the chance to speak with you all. You folks are going to be entering a world full of wicked problems, okay? There may not be an easy solution. There may not be a clear-cut outcome. You'll have to sort of critically think and approach every problem on a case-by-case basis and do the best you can with the information that you have sourced. So I think if you can understand how systems are used and leveraged against one another, you'll be better prepared to handle these problems. Thanks again, everyone. Again, I appreciate the opportunity to chat with you all. I'm happy to take any questions in the meantime, if there are any.
Thanks, Dr. Mohan. If anyone has any question, feel free to type that in, or you can unmute yourself and ask. If not, I had a question for you, Dr. Mohan, if that's okay. So you mentioned the pandemic preparedness scale and how the US and Canada are high on that scale. So to me, it seems like the pandemic preparedness is defined as how well the country is better supplied to transfer its drugs to the patients, not necessarily how reactive the country is to a pandemic. Is that correct?
I think this scale is primarily based on GDP.
Mm-hmm.
So I think it's based on how rich countries are. And you know, you can see that through Canada, US, and Australia. I think you see it here with England and certain countries. Whether they're able to actually implement those resources is different. So I think the scale was developed like primarily based on that factor. And I think a byproduct of having a high GDP is that you're able to have large storage of various supplies. And again, I think what's important is that we saw that not be the case with ventilators and PPE, right? And if you folks remember the devastating hurricane in Puerto Rico that happened a few years ago, I'm not sure if you know, but there was a shortage of saline bags in North America for about 6 months after that. And at that point, we all said, because they were essentially manufacturing Puerto Rico, and we sat back and we said, oh, this is a problem. We should remedy this in the future if something else were to happen. And lo and behold, that wasn't the case. And we were very reliant on folks out in the East for a supply chain, and that didn't work for our pandemic response. We were very reactionary, Keshi. We were very reactionary. We had enough data to know this is going to happen. You know, I was working, so when I was at FAC, the PHAC, just to be clear. I was on the surveillance coordination unit, and we had data relatively early about the virus, and we communicate directly with the US. So we know they had it in December. What countries do with that information and how they go about it, it's sort of, it's outside of, it's above my pay scale and my ranking. But that information is there. So do we have the ability to be a leader in global pandemic preparedness? Yes, but that also requires factors that are outside of public health control. So political will, and again, it can't just be federal, right? Because surprisingly, the federal government doesn't have a lot of control provincially. So Ontario has the ability to implement what Ontario wants to do, right? And you're seeing that. So you're seeing the response in the Atlantic provinces. If you go to BC, for example, it's a whole different world than Ontario. Likewise with Alberta. So, I think preparedness and the ability to actually enact it are two different things.
Okay, that makes sense. So you think for the pandemic too, the scale might change?
It depends. I think that depends. It depends what we value coming out of this pandemic. So we're seeing in Ontario right now that the virus is affecting BIPOC populations disproportionately.
Okay.
And nothing's being done to address this. So things like paid sick leave are not being addressed. We're not seeing enough isolation facilities pop up. And so you're seeing physicians sort of on med Twitter, which if you want to join, do it at your own sort of purview, because it sort of encompasses you once you're on med Twitter. But you're seeing certain physicians like Dr. Dasani, Dr. Della, Andrew Boji sort of advocate for these things, and they're speaking out loud, hey, we need these things because there's a specific demographic being hurt by the pandemic. The question becomes, coming out of this pandemic, are we going to prioritize these societies, or are we going to say, hey, we're good with the way the system is? And I think you folks are going to have a large say in that.
That makes sense.
Sorry, I just wanted to kind of carry on with that, and maybe other people may have interest in this as well, but you kind of talked about like the political aspects and the different kind of limits there are to your role in the Public Health Agency of Canada. But do you ever feel like the things that you try to implement or the effects that you try to make kind of like are limited no matter what because of the political climate and whatever other people are involved in the decision-making process?
Yeah, I was speaking to, I think, a reporter last week, and I was telling them that when I made the decision to go into public health and global health, the primary reason was it's hard for me to see medicine the same way once I understand population level health, right? So I can see a patient one-on-one, and I can prescribe a medication, and I can build that, and it feels great. Like when you make a change in a patient's life and you're helping them, there's a level of satisfaction and happiness that you feel. But once you realize that, I can control or I can help improve 100,000 people or 1 million people, it's hard to go back. The first time I actually missed clinical medicine was during this pandemic, because I felt so hopeless. Like the data that we're sourcing, the recommendations we're making, we know exactly what to do and how to attack this. And to sit back and watch the political powers that be pick and choose what to use in a non-science manner is disheartening. So I almost felt quite powerless in this regard, right? Like it's so tough knowing here's what actually helps, right? So when you lock down, in order to actually, so first of all, no one in public or global health wants a lockdown. Lockdowns suck, right? I don't know how else to say it. It's hard on folks' mental health. The economic devastation is huge. The downstream health outcomes that we're going to see as a result of the lockdowns are going to be catastrophic, right? So you talk about children in developmental years, you folks all in university years, which are quite important in your overall life, right? Like your university years are very important. Having that interaction with your colleagues in a non-Zoom manner is very important, right? So there's facets of the lockdowns that aren't good. But what we need from a lockdown is for it to be a strong lockdown. So as many parts of our society that we can close, the more effective our lockdown becomes. So now in order to close these parts of society, we need to provide economic aid to small businesses, to employees, to schools, etc. We can't have 1 foot in, 1 foot out. So yeah, to your question, it's quite frustrating. And Our governmental policies are sort of tied up in bureaucratic realities. There's a lot of red tape. To get something passed from one desk to another desk and to wait for an approval is just not an efficient system. Pandemics require proactive measures, not reactive, and our systems don't allow us to be proactive. We live in a reactive world, and that includes our data. Sometimes we have to make decisions with incomplete data sets, and that's just sort of the way it goes, right? And if you have inadequate surveillance systems, it's hard to sort of make real-time decisions. An example is that, oftentimes in the federal government, we are sourcing information through fax and paper still, right? So we're getting results from a fax machine. Someone picks that up and says, oh, great, let's go to the desk and we input the data into a system. That too, our systems are limited because we can't afford the amount of servers we need, right? Because what happens is governments decide how funding works. So public health, traditionally, when public health works, you don't know it exists, right? That's good public health. There's a non-pandemic world, things are working smoothly. When everyone talks about public health, it means something's happening that's really bad, right? So a pandemic. So now, it's unfortunate, but this is our opportunity to say, hey, can you increase our funding? Like we need more support here. We need more EPIs. We need to attract more physicians into public health. We need to attract more young talent like all of you into public health, right? Because there's a brain drain here, right? And so if we can build up the capacity and the baseline level up, we'll be better prepared for the future pandemic.
I kind of just wanted to add a question in there. You talk a little bit about the future and moving forward, and you also work with a lot of data. And I was thinking what your opinion or perspective was on the availability of big data and techniques such as machine learning and data analytics in decision making in the future. Do you think that it'll help make more quicker decisions and more informed decisions? And I just want to know your perspectives on it.
I think, yeah, thank you for that question. I think it's an inevitability. We have to, any member of healthcare, regardless of what your title is, you have to get very comfortable with big data. You have to understand how it's being used, how it's being sourced, and how it affects the end user, which in this case is a patient. So, for example, in certain labs in Ontario, they're already using artificial intelligence to make up certain gaps in lab data. Right. So 25% of our lab data is either it's not used either through contamination or through issues with the reporting. Right. So what we do is we use artificial intelligence to sort of help fill those gaps in. Right. In some cases, quite helpful. In some cases, we need more data. So the issues that I look at specifically when it comes to big data and sourcing data is the ownership of it. So patients have the right to their data. I think patients have a right to their charts. They have a right to, open access. They should understand, what we're collecting and why. And who houses, I think what people don't know, and it's publicly known, government data sets get hacked all the time, right? You can see how lucrative it would be for a private entity to know how many people are taking drug X versus drug Y. Are folks who make over $100,000 a year more likely to take Xanax over another drug, right? And can we target them? And the data analytics is extremely powerful. It can address many market inefficiencies, but it can also add to inequities in our healthcare system. And I think that's the problem that we're having. It's hard to understand how to approach this problem. Like it's really difficult. I don't think there's an easy answer here. It seems like we're building a plane in the sky. We know it's important, but the systems aren't ready to handle the amount of data we have. But we can't wait for the systems to scale up because we need that data right now for real-time decision making. And again, I'll highlight how problematic it is that we've only started collecting race-based data, right? And I think I'll highlight again, the reason for that is COVID is a disease fly from country to country. The folks that are dying from the disease disproportionately are BIPOC communities. In order for us to reopen our societies and our economies, we can't have COVID in any part of our communities, which includes poor communities. So what we had to do was start collecting race-based data to understand how the virus is being spread in these communities so we can actually address it. Again, this is a virus that affects all members of society, rich, poor, in between. The fact that we're in 2020, 2021 collecting this data now is scary, but we have it, so let's make the most of it.
All right, we have another 2 minutes in case anyone wants to squeeze in like a last minute question for Dr. Mohan. Or any comments, feel free to throw it in the chat or unmute yourself.
Another good lecture if folks want to watch is David Suzuki has one on population growth as well, where he uses a test tube as an analogy. Again, another interesting way to understand the realities of what we're going to be facing. And if folks want to dive down this hole even more, I would recommend everyone calculate their carbon footprint or their ecological footprint.
All right, thank you, Dr. Mohan. I think you definitely shed light on a lot of interesting aspects of health and global health and public health as a whole. I definitely am shocked that government data gets hacked as often as you said it does. But thank you so much. Thank you to everybody who attended. You'll definitely all be receiving an email shortly with our midterm survey as well as the resource sheet and your receipt of attendance. But thank you, everyone. Feel free to let us know if you have any questions. Once again, thank you, Dr. Mohan. Round of applause if anyone can through Zoom.
Again, thank you, folks. I appreciate the opportunity. Good luck in your careers in global health. If you have any questions, don't hesitate to reach out. I'll do my best to respond in a somewhat timely manner. I think Keishi can attest that I'm not the most responsive. It takes me a little while to get through my emails, but thanks again. Take care, everyone.
Thank you, Dr. Mohan. Appreciate your time.
Anytime. Take care.